Okay, we'll continue with chapter 1, but go on to classification of joints now. So before we go on to thinking about joints or thinking about that, this is a very interesting model that I want you to understand. The teachings of Greg Cook, Eric Dalton, what they basically say that each joint is either going to be mobile or going to be stable. And if one joint is not acting the way it should, then the joint above or below will try to compensate. And let me show you what that means. If you've seen some of my videos, stretching videos, I take this concept and I show you visually. But let's take a look at just the ankle. As you know, the ankle itself should be mobile. Okay, so we need mobility in our ankle. Now, if you have tight gastrocs or you have very tight ankles, I say ankles, but the joint itself, well, guess where you're going to try to compensate? The knee. That's right. So there's your ACLs and meniscal issues. The knee, we know, needs to be strong and stable, but the next power joint is the hip, and that should be very, very mobile. If you have hips that are super tight and they're not mobile, guess the two places that you're going to try to get mobility. That's your knee and that's your back. Think about all your athletes that have low back and knee pain. Have you ever looked at their hip? Have you ever looked at their ankle, even though they have knee issues? And when we did the chat, we talked about all you that have ACL injuries. Now, if somebody crashed into you, that makes sense to have an ACL injury. There's nothing you can do. But if you're just running and cutting and stuff, think about where the deficit is. You might have deficits in your ankle, you might have deficits in your hip, and guess what? When you run and cut, you're trying to compensate at that knee, and that's where the ACL just gives out, the meniscus just gives out. So some interesting things that you need to compensate. So when you're working with athletes, when you're working with your patients, even though they come in with knee pain, I want you to look at the hip. I want you to look at the ankle. Now think about this. The ankle itself should be mobile. So why do we tape our ankles and stabilize a joint that should be mobile? Obviously, more research is needed, but do you think taping the ankle where it should be mobile, now you're actually putting even more stress on the knee because you got to get mobility somewhere, right? So it's a very interesting concept. Now think about the lumbar spine. We know we need stability at our back. That's for sure. But if you don't have stability, then you'll try to get stability somewhere else. So then if you don't have the stability, your hips may become tight. So it can go both directions. But the key also is the thoracic spine. The thoracic spine should be mobile. So make sure you check those stretches that I've posted on YouTube for getting mobility in your spine. Because if you don't have mobility in your spine, guess what? Your back is going to move too much. There's your herniated disc. And then your neck's going to move too much because you don't have the mobility of the thoracic, so you'll compensate at the neck. And that's why you're constantly rubbing your upper traps, you're rubbing your neck when you've been sitting too much because you're trying to get mobility and your body is trying to compensate. So very interesting concept. Make sure that you realize this, and really you can rehab is a lot easier if you try to get mobility where it needs it. So you need mobility in the ankle, the hip, and thoracic spine, and stability at the neck, the back, and the knee. Okay? And if you don't have one or the other, then it will compensate either above or below the joint. All right, what are the classifications of joints? Articulation of arthrosis, type and range of movements are similar in all humans. The freedom, range, and vigor of movements are limited by the configuration of the bones where they fit together and by ligaments and muscles. So the type of bone it is will determine is it going to be movable or not. So that's very, very important. Configuration of the bones. Functional classifications, you're going to have joints that are either Syn Arthritial, Antarthronial, or Diarthordial. So Syn Arthritial joints, they're immovable joints that are divided into two types. Either sutures, that you have those in the skull, or gomphosis, no movement of teeth in the mandible or maxilla. So your teeth shouldn't be loose unless you eat a lot of Sour Patch watermelon kids and Coke. Then you'll get gomphosis that will just erode away, and then you'll get loose teeth. Okay? Now, amphiarthrodial joints, they allow a slight amount of movement to occur. Those are syndesmosis, symphysis, that's your pubic symphysis, and syncochondrosis. So syndesmosis is between your tibia and your fibula. You guys have heard about high ankle sprain. before, where you can actually tear the syndesmosis. Pubic symphysis, when you have babies, you'll sometimes separate the pubic symphysis. Yeah, good luck with that, ladies. Sorry. And then you have syncochondrosis, which are where your ribs attach to your sternum. Now, syndesmosis, two bones joined together by strong ligamentous structure that allow minimal movement between the bones. But if you have a huge fracture in your ankle, which some of you do or did, then you would have to replace it with screws, plates. Okay? Another example of ampiarthrodial is your corticoclavicular joint. Okay? And then, of course, the inferior tip fib. The symphysis, see that's pubic symphysis, see that separation? So there's that separation of the pubic symphysis. This is a female. Remember, the shape of the pelvis can determine if it's a male or female. Usually the pelvis of a male is usually a little heart-shaped, and then for a female it's oval-shaped, because remember, we want maybe an 8 or 9 pound baby to go through that right easy. If you have a baby go through this heart shape, you're going to get a cone head looking head. You ever watch that movie Coneheads? Yeah, that's what it'll look like. Now, synchondrosis, that's a type of joint separated by hyaline cartilage that allows very slight movement between the bones. So examples of that are costochondral joints. So make sure when you study the joints, you know what example is in the human body. So I would say, give me a type of synchondrosis joint. Give me a type of symphysis joint. So that's how you study that. Now, synovial joints, which are the diathorial joints, those are the ones that you're going to deal with most of the time. They're freely movable. When they're freely movable, they're going to be more prone to injury. The bony ends are surrounded by a sleeve-like covering called the joint capsule and secretes synovial fluid to lubricate the joint cavities. Unfortunately, after the age of 25, the secretion of synovial fluid can decrease. So yes, your joints can start to hurt after 25. You're an old man by then. Well, from an athletic standpoint. All right, the capsule thickenings from tough, non-elastic ligaments that provide additional support against abnormal movement or joint opening. And so you have this joint capsule. You can definitely injure this joint capsule, very common in sports. Now, we talk a lot about diarthrodial joints. They're articular, or hyaline cartilage covers the articular surface ends of the bones inside the joint cavity. When this articular cartilage, as you get older, tears away or goes back, unfortunately, it doesn't come back. There's no regeneration of articular cartilage. So you've heard of athletes that say, hey, my knees are bone on bone. Well, that's because the articular cartilage is pretty much gone. Okay, it can no longer protect the bone, and it can no longer absorb the shock. So every time they run, every time they walk, it hurts, because literally you are rubbing bone on bone together. They slowly absorb synovial fluid during joint unloading or distraction, and then secrete synovial fluid during subsequent weight-bearing compression. So what you can do is, if you have pain when you get up first thing after you've sat for a while in your knees, what you can do is just flex and extend your knee maybe 10-15 times before you get up. And what we'll do is your body will say, okay, you know what? They're going to put weight on this, so it will naturally secrete that synovial fluid, and it should help a little bit. So, if you have knee injuries and you have articular cartilage issues, sometimes just flexing and extending your knee a couple times before you get up will help secrete more synovial fluid. Range of motion is definitely important in sustaining joint health and function, so we always emphasize range of motion. Some diarthrodial joints have specialized fibrocartilage discs, provide additional shock absorption and load distribution, and further enhance joint stability. So what is the purpose of the menisci? What is the purpose of labrums? They provide more joint stability. So if you tear your meniscus, if you tear your labrum, now that's the shoulder, and then you can tear your hip labrum. Alex Rodriguez tore his labrum. A lot of softball players will tear their labrums because, unfortunately, when we talk about the hip, you'll see that, hey, if you have a very shallow groove and you put a lot of torque on there, you can definitely tear that labrum. Baseball pitchers will definitely have labral issues, pitchers especially. All right, diathorial joints have motion possible in one or more planes. We talked about the planes, right? Sagittal, frontal, transverse. So these joints provide motion in multiple planes. So one motion in one plane equals 1 degree of freedom. Motion in 2 planes equals 2 degrees of freedom. And motion in 3 planes equals 3 degrees of freedom. All sports require motion in 3 planes and 3 degrees of freedom. 6 types of diarthrodial joints. So now we're even taking diarthrodial joints and we're breaking those down. So we spent a lot of time on diarthrodial joints because these are the ones that you're going to see in the clinic. Okay, so arthrodial or gliding joints, they're 2 plane or flat bony surfaces that butt up against each other. So what are some examples of an arthrodial joint? That's your vertebral facets in the spine and the intercarpal and intertarsal joints. So knowing what type of joint and the examples is the way you would study for the quiz. A ginglymus or a hinge joint, that's a uniaxial articulation. Okay. Articular surfaces allow motion in only one plane, and that's the elbow, knee, and ankle joints. Okay. So that is one uniaxial, usually one plane, right? Flexion, extension. Now, if we look at really break down the elbow, the knee, and the ankle, they actually allow slight movements in other planes as well, but the majority of it is in one plane. Trochlear or pivot screw joint, they're uniaxial. They allow rotation of the radius on the ulna at the proximal and distal radial joints. Condyloid or knuckle joint, those are ball and socket joints. Examples are the 2nd, 3rd, 4th, and 5th metacarpal joints, and wrist articulation between the carpal joints. So remember, knowing what type of joint it is, that's the major one, diarthrodial, then the subset of the condyloid joint, and then knowing the examples is the best way to study for this. Antarthronial is a multi-axial ball and socket, so these are your hip and shoulder joints. So these are the motions that allow you can do flexion, extension, abduction, adduction, diagonal abduction, adduction, rotation, and circumduction. So these are the joints that we want to work on for sure. Okay? They're multi-joints, and in sports, this is what you're going to work with most of the time. Then you have cellular or saddle joints, which is a very unique joint. It permits ball and socket movement, and that's your CMC, which is the thumb. Okay, 40% of your movement comes from your thumb. Now here's an interesting question. If you were, let's say, kidnapped by the Japanese mafia, the Japanese mafia love to cut off digits. So if they say, okay, you have a choice. We're gonna cut off one of your fingers. Which one do you think is the least important fingers? Now they're all important, of course, but if you were to lose one, you wouldn't lose too much use of your hand. It wouldn't affect you as much because everything else would compensate. Which one do you think? You think it's the pinky, it's the middle finger, the ring finger, or the index finger? Thumb, we already said, is important. We need 40%. So thumb, tell the Japanese mafia, no, you can't have my thumb. You can have any other finger. But which finger would you give? Think about it. All right. So here's a good little example here. Now, still talking about diarthrodial joints. What would make it static? Bony architecture, cartilage structure, ligamentous, and connective tissue laxity would determine that. What makes it dynamic? Muscle strength, endurance, and flexibility, proprioception, and motor control. So increased joint stability leads to decreased joint mobility. This is that first slide I told you about mobility and stability. Increased joint mobility leads to decreased joint stability, right? So the more mobile something is, the less stable it is. Okay? And the more stable it is, the less mobile it is. And we talked about this. We want our ankles, we want our hips, we want our thoracic spine to be mobile. We want our knees, we want our low back and our neck to be stable. The other thing is if you have proximal stability, then you have greater distal mobility. So if your scapula is stable, then your hand movements are going to be a lot better as well. So if you have an unstable scapula, then your movements in your hand and wrist are going to be unstable as well. So that's a very important concept for pitchers, baseball, overhead athletes. We want stability in our scapula. Stability, mobility. The more mobile a joint, the less stable it is. Makes common sense. If it's sloppy and it's moving about, well, it's not very stable. Both hereditary and developmental factors, Wolff's law for bone and Davis's law for soft tissue, contribute to these variances. So we're going to talk about Davis's law and Wolff's law in just a sec. All right. So Davis's law, ligaments, muscle, and other soft tissue, when placed under appropriate tension, will adapt over time by lengthening. Conversely, when maintained in a loose or shortened state over a period of time, they will gradually shorten. So Davis's law is basically if you use it, you'll maintain good mobility. If you don't use it, you're going to get real tight. So imagine if you never stretch your shoulder, never stretch your hips, well then the soft tissue, the ligaments and muscle are going to become tighter. That's Davis's law. Okay, so Davis's law applies to soft tissue. Wolff's law applies to the bone. The more you stress a bone, it's going to lay down more bone. Davis's law is soft tissue only, ligaments and muscle. And most of our musculoskeletal issues are soft tissue issues. So, 5 major factors that affect total stability and consequently the mobility of a joint. What's going to affect it? Bones, cartilage, ligaments, muscles, and proprioception, motor control. Like I was telling you, most athletes are strong. Where they lack is proprioception and motor control. Okay? And I'll show you ways to test motor control a little bit later. Bones, usually very similar in bilateral comparisons within an individual. So your right humerus looks very similar to your left humerus as far as bone structure is concerned. Actual anatomical configuration at the joint surfaces in terms of depth and shallowness may vary significantly between individuals. So my right humerus may look significantly different than your humerus, but your right humerus looks very similar to your left humerus. Okay, so you have very little variations in the bone itself between the individual, but you have tons of variations in soft tissue between the right and left. So your right bicep may be different than your left bicep. Soft tissue is based on Davis's law. Do we use it? Do we stretch it? Etc., etc. Cartilage, structures of both hyaline cartilage and specialized cartilage structures such as the knee menisci, glenoid labrum, and our acetabular labrum further assist in joint congruency. So of course we need the cartilage to help us make the joint stable. Normally the same in bilateral comparisons within an individual. So usually your right glenoid labrum is going to be the same as left unless you're an overhead pitcher, right? Then if you constantly pitch, then your right labrum may get worn out versus your left. But if you don't play sports, if you don't play overhead sports, most of people, their cartilage is going to be the same. It's just when you use one side more than the other, one side is going to get more worn out. The concept is simple. Ligaments and connective tissue. Remember, ligaments have a very poor blood supply. They provide static stability. Joints, ligaments connect bone to bone. Variances exist between individuals in degree of restrictiveness and ligamentous tissue. The amount of hypo or hyperlaxity of an individual is primarily due to proportional amount of elastin versus collagen within joint structures. So the amount of elastin and collagen will affect how hypo or hypolax. And some of you can, bend your finger all the way back and touch your forearm, or you guys have hyperextended elbows or hyperextended knees. That's not good because you don't have stability there. Okay? Individuals with proportionally higher elastin to collagen ratios are hyperlax. So those individuals, you have too much elastin. You're loose jointed. Don't ever call somebody double jointed because that's not, no one has two joints. So you never want to say double jointed. That's a very poor use of medical terminology. Okay, you can be loose jointed, but once you get your degree, don't ever say that, hey, I'm double jointed. You'd be a very weird looking human if you say you're double jointed. Okay. Muscles, of course, provide dynamic stability joints when actively contracting. Without active tension via contraction, muscles provide minimal static stability, so we need them to contract. Strength and endurance are significant factors in stabilizing joints. And muscle flexibility may affect the total range of joint motion possible. We'll talk about muscles. We'll talk about stretching. Is it effective? Does it work? Does it not work? We'll talk about foam rolls. Do they work? Do they not work? As we get into the muscles. Okay? Again, I want to tell you what the facts are so that then you can share the information to your colleagues and your athletes. And then proprioception and motor control. Proprioception is subconscious mechanism by which the body is able to regulate posture and movements by responding to stimuli originating in proprioceptors embedded in joints, tendons, muscles, and the inner ear. When we do ankle rehab, patients with chronic ankle stability, we want to work on proprioception and motor control, because a lot of times they don't know where their joint is in space, and that's when they run into chronic ankle sprains. And the motor control process by which bodily actions and movements are organized and executed. So motor control is if you watch somebody squat, do they have control to go all the way down and come back? That's motor control. You know they have strong quads and they have strong glutes and strong hamstrings when you test them. But then when you see them do a squat, you're like, oh my God, what's going on here? That's motor control. Proprioception, to determine the appropriate amount of muscular forces and joint activations needed, sensory information from the environment and the body must be integrated and then coordinated in a cooperative manner between the central nervous system and the musculoskeletal. So the central nervous system, CNS, and the MSK system must work hand in hand, must work together. It's not just one thing to go there and do squats, 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 or leg press, leg press, leg press. If the brain doesn't know how to put it together, then all your effort, you can look good statically, as a bodybuilder, but if you go play sports or anything, then if there's no neural connection or proprioception or motor control, you're going to suck as an athlete. And so we want to work on motor control with our athletes. Muscle strength and endurance are not very useful in proper joint split unless activated precisely when needed. Structural integrity may be affected by acute or chronic injury. Structures adapt over time, both positively and negatively, to specific biomechanical demands placed on them. When any of the above factors are compromised, additional demands are placed on remaining structures to provide stability, which in turn may compromise their integrity, resulting in abnormal mobility. This is the first slide that I told you. If something is not mobile, it's going to compensate above or below. This abnormal mobility, that is hypermobility or hypomobility, may lead to further pathological conditions such as tendinitis, bursitis, arthritis, internal arrangement, joint subluxation. So all the itis brothers, so all these injuries occur because these joints are not functioning the way they are. So see, now you're understanding injury, but you had to understand normal. So you understand the mobility stability concept. Now you know you'll be able to pick out abnormal. So let's see what's the take-home message here. Let's discuss this, right?